Thank you for the invitation. And this is a kind invitation because not only do I get to speak to all of you, but I get to speak in support of a group that I am blessed to be able to work in this county with, which is Cognitive Care Solutions. And I just, I don't mean to make you blush, Allison, but I can't tell you what a difference in the last few years since we've been able to work together, especially through this time of COVID, to be able to have access to the level of care that you provide, which is fairly unique in the areas. And so we all are lucky to have dedicated therapists who have taken this up as an interest and found ways to get Medicare and insurances to support these needed interventions. We all understand how physical therapy works for people, and that is an important part of how we treat this disease and important in keeping the memory strong. But people don't realize the sort of care that goes into constructing the regimens that the therapists at Cognitive Care Solutions really do to focus on the brain. And I like it because, this disease, Parkinson's, that we're going to be mostly focusing on today, there's so many different levels of intervention in regards to memory that are important. One of the reasons I love working with this population is you guys are usually one of my sharpest group, and you challenge me, you bring things in terms of what you read and literature, and you guys usually will take it in and absorb it and implement it. And for that, I'm grateful to work with all of you, and you're my inspiration many times to always try to grow. And it's amazing in the last 20 plus years I've been in practice, how far this particular, our ability to intervene in this disease is. I've given lots of talks about motor symptoms, but the memory issues that can occur are really what we would call one of the non-motor symptoms. And it deserves some attention in and of itself because memory is something we all worry about as we grow older, depending on which stats you look at. Once we hit about age 80, it's estimated that, it's a coin flip. About half of us will notice some degree of cognitive impairment. And that's not even affecting, not even looking at the Alzheimer's population, the Parkinson's population itself. But about half of us will have a memory impairment by age 80. That could be MCI, mild cognitive impairment, or it could be, a dementia. Let's start by kind of defining those types of terms. Dementia is just that's the overarching category, right? That is any kind of cognitive impairment that is persistent. That could be from a physical injury, it could be from a stroke, that could be from Alzheimer's, which is a degenerative condition, or we can encounter subtleties with Parkinson's. But Parkinson's is a different variant, and I want to make sure I kind of compare and contrast it with the more commonly understood Alzheimer's. In Parkinson's, folks, usually when I first diagnose you and in the beginnings of the symptoms, most folks with Parkinson's in those first 3 to 5 years, that's when we're really watching to see if there's early cognitive impairment and memory problems and issues, or no, is it really just a little bit of cognitive slowing and sort of feeling like you're thinking in molasses? That's oftentimes how a lot of patients will put it. So in that regard, so in those first 3 years, I'm looking to make sure that you fit into the classic Parkinson's category. Classic Parkinson's folks tend to notice, very subtle issues over the years, but it could be 15, 20, 30 years or more before people sometimes will notice any true cognitive impairment that's sometimes measurable. On the other hand, there are some atypical versions of Parkinson's, such as Lewy body dementia, which is the second most common form of dementia, which might show up in the first 3 to 4 years after the diagnosis. That, Lewy body dementia is a very close cousin to Parkinson's, right? It's caused by the same abnormal proteins, alpha-synuclein, that has been damaged and is accumulating in the nerve cells. In Lewy body dementia, it tends to enter in early and here's our brain here, it tends to enter in early up into these cognitive areas of the brain. Parkinson's tends to stay in the basal ganglia, in the motor circuits of the brain. And so it's kind of important, but it's the same pathologic process. It's just which part of the brain is it affecting in the earliest stages. So again, in Parkinson's folks, it tends to stay here in the basal ganglia, and it's only subtly affecting the thinking. In Lewy body, when it affects up in the frontal lobes and the temporal lobes, we start to have sometimes visual spatial dysfunction. We're starting to notice some issues with visual hallucinations and along with memory and attentional issues. Okay. But that's usually, again, Lewy body dementia is, it tends to show up earlier. We tend to have early hallucinations and earlier behavioral issues, earlier sundowning phenomenon. But in Parkinson's, most folks in those first 3 to 15 years, most of the time, all of you would usually tell me, gosh, I still know what I want to say, but it's harder to get the words out, or it's harder to get the thought out, or people need to be patient and allow you the time to respond. That response time is really, critical. And that's what one of the things I've learned around my patients and that they have taught me. It's just be patient, give you the time to respond, because those circuits are still working, but sometimes they're operating a little more slowly, but still fairly accurately. Okay, so that's called speed of processing. And so that's probably the most prominent phenomenon, and most Parkinson's patients would notice a little bit of that. And then we watch over time. Usually, if that speed of processing becomes significantly impaired, that's where working with places like Cognitive Care Solutions can sometimes help. And that's oftentimes where we start. That's oftentimes where physical activity, whether it's physical therapy, walking, and exercises, can help improve that speed of processing. It's oftentimes why I might, also be initiating your Parkinson's medicines, right? The dopamine replacement therapy for Parkinson's. And surprisingly, a lot of my Parkinson's patients say, hey, that does help. I was noticing really thinking in a fog, and I was really thinking slowly. And then once my mobility improved with some of the kind of carbidopa, levodopa medicines like Rytary, Cinemet, those types of medicines, hey, my thinking did improve a little bit, and my motor function and walking improved quite a bit. So sometimes it's as simple early in Parkinson's as, getting you into, physical activity, working on potential cognitive therapies, and just the normal Parkinson's treatment medication-wise that we know helps mobility, can also help with thinking. Okay. Also, in that first 3 to 15 years, if you're noticing some challenges, there are other cognitive impairments that might look like dementia, but they might be more associated with mood disorders. In Parkinson's, we know there's a high risk of either anxiety or depression. In Parkinson's, we always talk about dopamine deficiency being, the predominant part of it. But with anxiety and depression, it also tells us that other neurotransmitters can be deficient, similar to the dopamine. The two that are most important are serotonin, very important in mood and anxiety and depression issues. And so a lot of the medicines in the SSRI, serotonin reuptake inhibitor class, these are medicines like Lexapro, citalopram, also known as Celexa, medicines like Zoloft and Prozac. These are all medicines, these are all names of medicines in that category, all of which can sometimes help with the anxiety and depression, which, if you think of anxiety and depression, it's a little bit like static on the radio in the brain. And it can be a distractor. It can take up useful function of the brain, by distracting you with these things we perseverate on, or we're worried about. And so alleviating the anxiety can get rid of some of these this background noise. I always think, your memory's like the music on a radio. And I've used that analogy many, many times in my office. And what I'm trying to do is try to get rid of some of this background static on the radio. Anxiety is one of the things that can cause the background static. Many of you would also tell me, well, gosh, when I don't get a good night's sleep, my thinking is really bad the next day. And that's true. And I know sleep disruptions can affect a number of patients with Parkinson's. And so oftentimes you and I will work together to try to find both non-medication as well as medication effects that can help improve the quality of your sleep. Or sometimes I have to remove things like nighttime caffeine that might be interfering with your sleep, as an example. So usually you and I are looking at and analyzing all of the qualities of your sleep. Sometimes it's nightmares or movements called REM behavior disorder that can be sometimes disrupting you or your partner sleeping next to you, because sometimes you'll be moving and be a very active sleeper. And, sometimes you'll be moving around or fighting off ninjas in your dreams, or sometimes calling out. And, sometimes that wakes you up. Sometimes it doesn't. But sometimes it wakes up the partner who then wakes you up. And sometimes that can be disruptive to your sleep. Depending on its severity, sometimes we'll treat that particular sleep disorder. That doesn't happen in everybody in Parkinson's, but when it does, it can be important to address it. Likewise, insomnia, if it's persistent, we look for all of these non-medication causes. We try to simplify your regimen. We try to get you into exercise programs, which can help regulate your sleep-wake cycle. And if that doesn't do the trick, we may look at supplementation with things like melatonin over the counter, or we may even go so far as to use certain types of sleep medications that may add it. I always try to delay the need for the sleep medicines, but realize, you have a very real disorder. And as part of that degenerative process, it can, in some people, affect those sleep circuits. And I can't let you just have intractable insomnia forever, because that is definitely going to make you feel worse in terms of your ability to focus the next day and remember things. So, and remember, most of my Parkinson's patients tend to have insight to their memory disorders, right? You can usually tell me the types of things you're having challenges with, and, having a hard time remembering or picking up on these things, trying to remember the name of certain actors or actresses, or, sometimes remembering your doctor's name. That's very, very typical in these types of situations. And so, those oftentimes, looking to see what could be exacerbating it is our first steps in approaching it. Okay, so those are, other things that can affect people in these first 15 years, when sometimes the symptoms are a little bit more subtle, is we also look for other, shall we say, physical or constitutional problems that may be part of Parkinson's or connected with other medical disorders. I'm going to use an example of one that I've been very pleasantly surprised at how much it helps people's thinking. And this will surprise you guys, or maybe it won't surprise you, but it's estimated 80 to 90% of Parkinson's patients have some component of constipation. Now, constipation by itself is miserable, right? Nobody likes it. It's uncomfortable for anyone and everyone of all ages. But in Parkinson's patients, right, constipation can also delay the absorption of your medicines. And so, it can have a really, really meaningful and direct impact on your thinking. So me being proactive with treating your constipation, which I've now learned over the last 20 years, really can help try to keep some clarity of thought, as well as help your medicines kick in. But, sometimes I have to use prescriptions medicines, like this is, I know it's backwards, but it's called Linzess, or over-the-counter medicines like Miralax, and Colace and fiber, and even just simple foods like prunes and hydration and and papayas. These are all some basic ways that we can always start with diet and then progress into more aggressive anti-constipation treatments. One of the other things that can affect folks, and this we become more sensitive to as we age, constipation can cause bacterial overgrowth. And that can lead to productions of things called ammonia. Ammonia is a toxin. It's a normal byproduct from the breakdown of amino acids and protein in your gut that the bacteria do. And if there's too much constipation, the bacteria have too much of a chance to work on the protein and create ammonia. And ammonia causes a certain amount of confusion, difficulty with focusing. This is one of the treatable, reversible things, equal to treating dehydration and making sure all of you stay hydrated to keep up the clarity of your thinking. But, constipation can allow for some of this bacterial overgrowth and the excess formation of ammonia. And it's subtle and it can vary. We've seen it in folks of all ages. It's why, both adults and kids can get, kind of sometimes irritable and behaviorally difficult when we get constipated. We don't feel well with it. And there is a very real physical reason for it. So, we usually treat it for other reasons, but just know that you are helping your brain by keeping, your colon moving, which I know all of you really, press upon us, the neurology team, but also the primary care and the GI doctors. And it's worth being proactive with it. Okay. So those are some of the kind of the general medical conditions. One other that sometimes gets short shrift in our office, but is oftentimes seen or will refer you to a sleep specialist or a pulmonologist is sleep apnea, right? Just because you have Parkinson's doesn't mean you couldn't potentially have sleep apnea. Sleep apnea are pauses in your breathing at night. In those pauses, your oxygen level starts to drop. And that can be disruptive for the brain's normal recuperating process every night. Sleep apnea can be recognized during a sleep study by this drop in your oxygen levels, but also the sleep specialist will detect when your airway relaxes and you have these pauses in your breathing, your brain has to wake itself up to breathe normally. Now, you may not remember that. Sometimes your partner in bed remembers that, but you may not remember it. But your brain on a sleep study is showing that it's getting woken up multiple times every evening. That's like the equivalent of somebody, every 30 minutes just kind of, shaking you awake. Nobody would like that. All of us would have a very disrupted sleep if somebody were doing that all night. And you all know where that happens. That happens in the hospital because the nurse is taking good care of you, but they're oftentimes waking you up. That's why nobody sleeps in the hospital. But, sleep apnea can cause a very similar pattern of disrupted sleep in people. If we identify that, that's again a separate medical condition that deserves treatment, oftentimes with a breathing treatment called CPAP. And so ideas that, sometimes and oftentimes the patient's not aware of it. And usually your significant other and partner can give us some insight of like, that may be there, maybe that deserves some separate attention by the sleep specialty team. Okay. All right. So we talked about a lot of these issues that happen in the, that can occur in those first 15 years that a lot of Parkinson's patients encounter. But sometimes as we get later and we start getting 10, 15, 20 plus years into the disease, sometimes certain issues may start to occur. And so those issues could be sometimes attentional issues, focus, energy. Many times those are indicating that, again, up in the frontal lobes of the brain, we're beginning to have a decrease in one of the other neurotransmitters. We've talked about dopamine. That's important in movement, tremor, stiffness, slowness. We've talked about serotonin that's involved in anxiety and depression. But there's a third one I like to mention, which is norepinephrine. So norepinephrine is the brain's version of adrenaline. And so as kids, there's a certain number of young people who have deficiencies in norepinephrine, and we know it as attention deficit disorder. Hard time focusing. Sometimes, and as we get older, norepinephrine deficiencies here in the hypothalamus, here in the brainstem, and here in their projections up into the frontal lobes. When we have those deficiencies, you can encounter fatigue, focus problems, balance problems when norepinephrine becomes deficient. The other insidious symptom is something known as apathy. So apathy, we would define that as difficulty with motivation, right? You kind of have lost your get up and go. You've lost your, maybe you were the person who was always getting people to do things. And then suddenly you respond, you'll go out for a walk if somebody, suggests it, but you won't always initiate as often. So that's apathy. Apathy is not depression, and it's not sadness. It's this sort of loss of motivation. And many times the significant others and loved ones will notice that and bring it up to us as, oh, this is a big change in this person's behavior and personality. And it is. It's especially characteristic in those who were movers and shakers and go-getters. When that begins to impact the patient, then, that's usually indicating this deficiency in norepinephrine. Similar to the kids with attention deficit, sometimes in those select cases, not everybody, but in these select cases, we'll use medicines like Ritalin or Adderall to raise the levels of norepinephrine in the frontal lobes and help with the speed of processing. It'll help with focus, attention, balance, energy, and it's the only family of medicines that works against apathy. So these are all, we selectively approach these issues, but all of these can be kind of lumped into these different cognitive impairments that people are noticing. And there's very strong anatomic correlations with what's going on in the brain that's causing this. This is not volitional on your part, right? You didn't choose to do that or feel that way. And that's important to convey to both you and your family members. But if it's risen to the level that it's beginning to bother you and impair your relations or your ability to function, then it's the right time to intervene. And I'm giving you guys some concrete times and examples of things and the different manifestations that present this way. Okay. So I also want to talk, and again, this is Parkinson's specific. And then my next topic is I'll talk just a little bit about how Parkinson's cognitive issues that we've done a lot of talking about vary from Alzheimer's. Okay. So Parkinson's can sometimes encounter some of the similar cognitive deficits of memory and recall that we see in Alzheimer's, and the memory medicines that you're all familiar with, something like donepezil or Aricept, or the old Exelon patch called rivastigmine. These are good memory medications, as well as a separate family called memantine, used to be known as Namenda. So memantine and the cholinesterase inhibitors, donepezil and rivastigmine, these are all really good medications that will sometimes frequently be used in Parkinson's cognitive impairments. Sometimes in the early MCI, mild cognitive impairment, and definitely it's something that we can use later as well. That's one of the big overlaps between Alzheimer's and Parkinson's. But my Parkinson's patients tend to do relatively well and tend to tolerate the medications. And oftentimes, because you're so aware of some of the cognitive deficits, you're usually able to tell me when the meds are making a little impact. Either you notice it or your loved ones notice it. And so, I really, in my Parkinson's folks, I really need some of that feedback. Let's contrast that with Alzheimer's. Alzheimer's folks, let's go back to the brain for a second. So if these is your frontal lobe, underneath it here, there's your temporal lobe. And this yellow area of the temporal lobe, that's your hippocampus. It's way under there. If we're looking at the lateral part of the brain, the temporal lobe is here. And the area I'm talking about is where my finger is. So your ear would be out here where my finger is. This is the temporal lobe. And then I come around to it. And that's, called the hippocampus, and that's the memory center. In Alzheimer's, that yellow memory center, that's the main area that degenerates and declines and is affected by Alzheimer's. In Parkinson's, sometimes that can have subtle impairments, but it's not usually as dramatic as the Alzheimer's folks. The other big difference between the two of you is my Parkinson's patients are frequently aware of some of their memory problems, the majority of the time. My Alzheimer's patients tend not to be aware of the cognitive impacts. There's this lack of insight to their impairments in a large number of cases. Oftentimes it's the family member in the Alzheimer's patients telling me, "Ooh, boy, this person can't do these activities. They can't drive their car. They can't handle their checkbook. They're getting their meds mixed up. They can't use a microwave anymore." And then the patient's like, "No, I'm fine. I don't know what you're talking about. I'm fine." And yet the person is clearly impaired when I do testing. That is very clear in the Alzheimer's folks. In Parkinson's, it's oftentimes, again, much, much more subtle. You may also have some impairments, but they tend to come on more gradually. It tends to be more subtle, and it tends to show up oftentimes many more years into the disease. Okay, so that gives you a little bit of a difference in terms of where it's impacting them and sort of how it's impacting them. And what are some of the differences between them. But one of the things that can affect both in more severe cases, sometimes we start to have issues with, inversions of dementia, and then especially in Parkinson's disease dementia, we can get something known as psychosis. So psychosis, what does that mean? Psychosis means that, you're beginning to have either hallucinations or delusions. Hallucinations are things we see that other people can't, or things that we hear, voices, sounds that other people can't. So that's, or sometimes even feeling things. I had one patient who swore they could feel somebody getting into bed with them, and there was nobody getting into bed with them. That's a tactile hallucination. So those are all possible manifestations of hallucinations. Sometimes the patient has quite a bit of insight to it. Sometimes they don't, right? And so sometimes the caregiver or loved one has to talk them down from it. And tell them, no, that's not there, and that's real. And it's good. My patients always do best with a trustworthy caregiver or loved one who then I had always advised the patient to trust what the other person is telling them. And if the patient's not sure, I'm not sure if that's real or if that's not, then you ask the person you trust, and they'll always be honest with you and straight. And that will help you have an idea whether something is a hallucination or not. Delusion, what does that mean? A delusion, another manifestation of psychosis, delusions are fixed false beliefs. For instance, paranoia, if I'm worried about somebody, trying to get into my house, or somebody trying to steal from me, or, that somebody is going to hurt me. Those are all, these are all persecutory delusions, right? That we have this feeling like something's out to get us. Or you can have other delusions like, oh, maybe my dead spouse is still alive, or my passed away parents are still alive, right? These would be fixed false beliefs, and sometimes we can redirect the patient away from it. So again, if we have delusions or hallucinations of any type, those are manifestations of psychosis. That doesn't necessarily mean people are always like angry or agitated, although those can be some of those manifestations, that we can have those behavioral appearances, especially into the evening. And that's a problem called sundowning. I see it, I can see that in Alzheimer's. I can see that in Parkinson's dementia, and I definitely see it very commonly in Lewy body dementia. And so how would I go about treating that? There's two really good treatments that work for it. One of them is the only FDA approved medicine. And so that's one called, now this is backwards, but it's called Nuplazid. And this one's really good in my Parkinson's patients, or even the Parkinson's-like patients called Lewy body. And it's the only FDA approved medicine, but it does not interfere with or cause tremor or a worsening of the Parkinson's symptoms. And it's usually not particularly sedating. So this is a good choice when those hallucinations and delusions, these manifestations of psychosis, are beginning to rise to the level that it's interfering with your daily function. For instance, an example of somebody who we might not treat is maybe you look out into the tree out your window and maybe you see a monkey in the tree, but there's no monkey up there. Or maybe you see kids running around the house, but they're playful and they're not bothering you. If it doesn't bother you, we don't always treat it, but we certainly can. But those are two examples of visual hallucinations, which we may or may not treat. If, on the other hand, somebody was hearing voices that were telling them to hurt themselves or making them very anxious or agitated, that's really not acceptable. I would definitely want to treat that psychosis. Or if you were feeling persecuted and you were feeling very paranoid in a regard, that's not fair. That's uncomfortable for people to be experiencing. Both the patient and the caregiver will be very aware of that. Then it's really worth treating. Nuplazid is an example, and in my ideal world, I would get to use it first line. In the real world, I can't always get it approved by the insurance, in which case we use a different medicine, used to be known as Seroquel, but the chemical name is quintiapine with a Q, quintiapine. And in Parkinson's folks, low doses, little whiffs of this medication can go a long way to really helping people. And so that's something that I wanted to make everybody aware of, that sometimes, you don't have to live with the delusions, agitation, hallucinations, sundowning that can occur with this. Or sometimes it just may feel just like constantly present anxiety. And so these are things that we can calm and soothe, with the medicines that work against psychosis. And those happen to be the top two. There are others, but by far and away, we try to stick with those two, in the top category. And sometimes, again, some of the anti-anxiety medicines like Lexapro and Celexa, citalopram, these medicines are also very helpful at, aggressively treating the anxiety when it rises to that level of discomfort, right? There's always a spectrum, right? A little bit, you might not have me treat, but there's always a line it crosses. And when it crosses that line, then you and I are ready to try to alleviate those symptoms because, it's uncomfortable. Okay. All right. Now, there's one other brief manifestation I'll talk about that can sometimes show up, and then I'm going to open myself up for questions. And one more thing before I move on to this next subject is that, remember, dementia in Parkinson's is not a foregone conclusion. Not everybody gets it. We're at higher risk beyond the 15-year mark, but, most of the time in classic Parkinson's, it's a very late phenomenon, and there's quite a few of my patients who never really meaningfully experience it. But just know that your neurology team is always vigilant for it, along with you and your caregiver. One other thing that can happen that it's one of the non-motor symptoms of Parkinson's that can occur in about 25% of my cases over the course of their disease. And that's one of the reasons we're aware of it. And I wanted to at least discuss the difference from either dementia or anxiety. And that's a problem involving the frontal lobes called pseudobulbar affect, or PBA for short. As a result of the Parkinson's and the slow injury to the nerve, sometimes we lose some of the nerves up in the frontal lobes that regulate our emotions. And if you're experiencing the following, if you're noticing that you get easily emotional, um, if we're at a funeral, it's okay to cry. If we see a really sad movie like Old Yeller, or something that really generates strong emotions, there's nothing wrong with shedding a few tears. Or likewise, you hear a great joke. There's nothing negative about, laughing at a good joke. But sometimes, because of the injury to the frontal lobes, people will have an inappropriate expression of emotion. For instance, maybe they'll see a mildly sad commercial, and then they'll get really, really kind of choked up, and you'll hear it in their voice, and you'll see it in their face. And I'm demonstrating it for you on camera, as well as the sound of my voice. And it's like there was a small trigger, but then it created like an excessive response. Like maybe people would tear up with that small trigger. Again, appropriate to do that at a funeral, but not appropriate to maybe do it with a very small trigger like a mildly sad commercial on TV. So that's an example of, how it can sometimes manifest. Likewise, let me give you another example, inappropriate, excessive laughter at inappropriate times, or like laughing at a joke, but like excessive laughter. Or an even better example would be like somebody tells you a joke, you start laughing, but then the laughter turns to kind of a sobbing. And so you start like, and it changes it like oddly into like a crying manifestation. Or you're at a funeral, which it's appropriate to cry at a funeral, but then your brain misfires and you're laughing and it's out of place, right? There was a misfiring and a dysfunction of sort of the frontal lobes recognizing that. These are all examples of pseudo-bulbar affect. And it is something that we do have an FDA-approved medication that can help your frontal lobes regain their ability to filter this appropriately. And, because it can be sometimes very disconcerting for people. Oftentimes, I will encounter the same phenomenon after a concussion, head traumas, or that we can get after a fall can suddenly unmask this particular problem. I've had it happen after strokes and in other neurologic degenerative diseases like Alzheimer's, but it can occur in Parkinson's. I'm just letting everybody be aware of it. I don't want you to think it's a foregone conclusion that you're going to get it. It's a smaller group of folks, but when it does occur, just know that we can treat it. We use a medicine called Udexta for that problem, and it's a long-acting version of a cough medicine. You've all had probably Robitussin DM, Robitussin cough syrup, which is dextromethorphan, and this is a low-dose, long-acting version of that cough medicine. And it's not going to work for your cough, but it is going to work to suddenly stop that sort of inappropriate firing of that laughter, getting choked up and emotional issues if it's disconcerting to you. So these are all kind of different manifestations, that people might mistakenly blame on anxiety or depression, but the person's not anxious and they're not depressed, but they are getting kind of this misfiring in the expression of their emotion as we see it from the outside. And it can make them feel out of control. And what's interesting is, sometimes this new Dexta medicine, I'll use it for sometimes I'll use it for their lifetime. Sometimes I'll use it for a year or two, and then suddenly I can pull it away and the patient doesn't need it anymore. We've retrained your brain to, to go back to regulating that emotional expression normally. So it's not an antidepressant. It's actually helping with this, expression of your affect, of this, kind of stopping this misfiring from happening. Okay, so I talked about a lot of things from a lot of different directions, gave you guys some suggestions on some general medical conditions that can be helpful. And this is always things worth talking with your neurology team, about if they begin to escalate. And, it allows us to intervene sooner, or at least do cognitive testing that is useful at identifying where the areas are that you could use help. And that, it's a lot of the cognitive testing, not a scan, not a blood test, but like memory testing. That's what usually helps us determine where your strengths and weaknesses are. That then we can direct cognitive care solutions, or we can direct certain medications to helping you. All right, with that, Allison, if I can, I'd like to open it up to questions at this point.